Hello and welcome. You know the scene. A patient walks up to your counter and just says, "I'm constipated." And you're thinking, okay, where do we even begin? It's easily one of the most common complaints we handle, but the right recommendation is so rarely just grabbing the closest box off the shelf. So today, let's walk through a really clear framework for counseling on adult constipation, from that very first triage question all the way to an effective treatment plan.
All right, first things first, let's ground ourselves in the official clinical definition, the Rome 4 criteria. This is our textbook framework for what functional constipation actually is. And as you can see, it's not just about how often someone goes. It's a whole cluster of specific symptoms, the straining, the hard stools, that really frustrating feeling of not being finished. This is our clinical starting point.
But of course, patients don't walk up quoting diagnostic criteria, do they? They come in with their own idea of what constipated means. You know, for one person it might be, "I didn't go today," while for someone else it's all about painful straining. So our job really starts with translating their personal experience into information we can actually work with.
So to bridge that gap, we're going to follow a simple 5-step roadmap. We'll kick things off with that initial patient encounter. Then we'll dive into our critical triage process. After that, it's all about foundational lifestyle counseling. Then we'll navigate the laxative options. And finally, we'll talk about tailoring our advice for some key special populations.
So let's start right at the beginning, that initial encounter. Our first step is to get really specific. We've got to ask questions like, what's a normal bowel routine for you? And of all the things you're feeling, what's the most distressing part? You see, pinpointing whether it's the frequency, the hard stools, or maybe the bloating, that's the key to making sure we're solving the right problem.
Now, before we even think about recommending a product, we have to shift gears into what I think is our most critical phase, the pharmacist's triage. This is where our primary role really kicks in, making sure our patient is safe by ruling out anything that needs a doctor's attention first. And that brings us to the most important question we have to ask ourselves and our patient every single time. What are those alarm bells? The red flags that tell us, hold on, this isn't a simple case for an over-the-counter fix.
And these are the big ones we're looking for. Any one of these, unintentional weight loss, any rectal bleeding, or a really sudden change in habits, especially in someone over 50, that's a non-negotiable immediate referral to a physician. We have to remember, our job here is to screen, not to diagnose.
Another huge part of triage is playing medication detective. We have to take a look at their profile. Is an opioid causing this? Or maybe an iron supplement, or one of the many drugs with anticholinergic effects? Identifying a drug-induced cause is a massive win, and it's a key part of our role as the medication experts.
Okay, so once we've figured out it's safe to self-treat, we still don't jump straight to the laxatives. The conversation absolutely must start with lifestyle. These non-drug strategies are the absolute foundation of good constipation management, and it's a step we should never, ever skip.
You know, there are really 4 pillars to this conversation. First, tell patients to increase their fiber, but to do it gradually to avoid gas and bloating. Second, and this is crucial, you've got to emphasize that fiber needs water to work, so they have to bump up their fluids too. Third, encourage regular physical exercise. And finally, don't forget the simple trick of using a footstool. You'd be surprised how much proper positioning can make a huge difference.
Okay, so the patient has that foundational lifestyle advice. What's next? Let's move on to actually picking a product. This is our guide to navigating that aisle and providing effective, evidence-based relief when lifestyle changes just aren't quite enough on their own.
The best approach here is stepwise. Lifestyle is always step 1. Step 2 is where we bring in a first-line agent, and that's typically going to be a bulk former like psyllium or an osmotic like PEG 3350. Now, stimulants like senna or bisacodyl, we generally reserve those for short-term relief or for more stubborn cases.
This table right here is a perfect little cheat sheet for counseling. For psyllium, the key point is fluid. They must take it with a full glass of water. For PEG, you want to let patients know it's a great, safe, long-term option, but it's not instant. It can take a couple of days to kick in. And when you're recommending stimulants, always counsel on the chance of cramping and really stress that they are best for short-term use.
And you know, when it comes to the osmotics, the evidence is pretty clear. For chronic constipation, PEG 3350 is definitely preferred over lactulose. And why is that? Well, because it's been shown to be more effective at improving stool frequency. And honestly, it's just better tolerated. It causes way less bloating, gas, and cramping.
Okay, time for a quick but very important myth buster. Let's talk about docusate. For years, it was the go-to stool softener, right? But the evidence just isn't there. The current guidelines are really clear on this.
Docusate is ineffective for treating constipation, and we should not be recommending it. This is a super key practice update for all of us.
All right, let's move into our final section, tailoring our advice for special populations. These are the patients we see every single day where, a one-size-fits-all approach just isn't going to cut it. For pregnancy, the hierarchy is crystal clear. Always start with lifestyle advice. The first-line agent is a bulk former like psyllium, mainly because it isn't systemically absorbed. Stimulants can be used short-term, and PEG is an option for tougher cases. But what to avoid is just as critical. You want to steer clear of mineral oil, castor oil, and saline laxatives because of their potential risks.
And for breastfeeding mothers, the approach is pretty similar. Bulk-forming agents are preferred, magnesium hydroxide and short-term stimulants are also considered acceptable. The big takeaway here is that for a lot of the newer agents, like linaclotide and prucalopride, we just don't have enough safety data to be able to recommend them.
Finally, let's touch on opioid-induced constipation, or OIC. This is a completely different beast. Because opioids slow the gut down, adding bulk with psyllium can actually make things worse, like a traffic jam. The crucial takeaway is that first-line therapy for OIC starts with an osmotic or a stimulant laxative. If that's not cutting it, it's time to collaborate with the prescriber about prescription options or maybe even rotating the opioid.
So as we wrap this up, let's just remember this. Our role goes so far beyond just picking a product. We're there to triage, to educate, and to empower our patients. At the end of the day, the goal isn't just about a bowel movement. It's about improving that person's quality of life. And the counsel that you provide at the counter, that's what truly makes all the difference.